Today, I'm going to talk about the challenges faced in our environment in particular, rather than a very basic talk on how VSDs have to be managed. So essentially, we are looking at three categories: infant with a large VSD, and I'll specially talk about the challenges in our part of the world when it comes to infants with large VSD, older child with PH and VSD. It's again a challenge that we face, and restrictive VSD. How do you manage restrictive VSD? So, Mahesh, I've started. So now the challenges that we face in low and middle income countries with the VSD are relating to undernutrition, pneumonia, and pulmonary hypertension. Pulmonary hypertension, of course, relates to older children primarily, but we're talking about undernutrition and pneumonia. So I'm going to share some data with you after I show you one particular case as to how this can impact our management and outcomes, and what some of the research that has been done in our institution, which has really outlined how these patients should be managed. So we'll take one example, and this was 1999, long ago, when we started looking after babies with, started performing open heart surgeries in little babies. We had this child who had presented at 2.5 kilos at 3 months, at 6 months really, and had lost birth weight, lost about 500 grams from his birth weight. And this child underwent a VSD closure after much deliberation, because we were very scared about operating on a small baby who was undernourished, and we felt that we can't salvage this baby. This was a different paradigm at that time. At that time, we were conditioned to believe that malnutrition is so bad that people will not tolerate open heart surgery after malnutrition. So we operated on this child, and this child actually did well. But we actually decided to analyze our data. We decided to analyze our data and looked at the first 100 VSDs we did with undernutrition. And we had, this is a paper that was published in 2002. But we had done, at that point of time, we had done surgeries on children who had a Z-score on an average approximately -3, really 2.8, and they were obviously having significant undernourishment with large VSDs. The average VSD size was 8 millimeters. And what we found was that age, weight, length, and even the presence of preoperative pneumonia and preoperative ventilation did not influence outcome in the form of death. This was in our earlier series, so we did a few patients. Nowadays, we don't have death as an outcome, but earlier we did lose some patients, and it didn't seem to influence whether or not they died. The surgical mortality for this subset at that time was 5%. Postoperative infection likelihood was more with younger babies and those who were preoperatively ventilated and those who had preoperative pneumonia. But postoperative infection wasn't influenced by the weight. So this was an important paper because nobody had published any data on these patients until then. We then looked at ventilation duration, ICU stay, and hospital stay. And again, we did not find any impact of weight or length Z-score on ventilation, on ICU stay, and hospital stay. Of course, preoperative sepsis and preoperative ventilation were big impact factors in this particular series. We decided to look at our more recent data, the IQIC data base 2010 to 2012. We've got 200 patients nearly, and VSDs constituted nearly 20% of our surgical caseload during this time. We've had 73 children with weight Z-scores under -3, that means severe malnutrition. Under 3 was 125 patients. minus under 4 was 68 patients, and minus under 5 was 27 patients. So these were the really malnourished patients. So we looked at comparisons on ICU stay, ventilation, hospital stay, and sepsis, and again did not find any relationship with weight. So essentially we came to conclude that it doesn't matter. If you're, no matter what the weight is, you can essentially perform safe surgery. However, we do encounter few patients every now and then who get stuck and end up requiring a tracheostomy, such as this baby which I showed you as the first example. Few examples of extreme malnutrition that influence outcomes, but by and large, as a group, nutrition does not impact early surgical recovery, does not impact ICU stay, does not impact hospital stay, and does not impact sepsis. So nutrition should not be a reason to delay surgery. The first instance, you come across a large VSD which is unlikely to close in an infant, we should endeavor to close the veins. That is the lesson that we learned, and we implemented that lesson. We have been doing exactly that. On this particular baby, I'm just showing you what happened. 6 months later, we had a very impressive return towards normalcy. But what is really interesting is that these children don't gain weight at the same pace as somebody else who as their normal peers. So if you see this particular study that we again published 4 years later, where we looked at somatic growth after VSD closure in malnourished infants. So we took the same subset of patients that we had analyzed in the first study and followed them and looked at 90 of those patients who were available. Out of 100, 90 were available, and we had data at follow-up for approximately 50, nearly 4-year follow-up was available. And then we looked at the weight gain. And if you see in these patients, the weight gain, if you look at the trends, none of those patients actually, very few of them really reached normalcy. Almost everybody, their Z-scores improved considerably, but they were still in the minus range. So that means the nutritional, and it was even worse with height gain. Height gain was very poor. So it actually was a very worrisome finding that if you start off with very severe malnutrition, you're operated for a VSD, the overall return to normalcy is not very good. They don't tend to gain weight at the same pace as their patients who are not malnourished and who don't have heart disease. So if we look at a multivariate analysis on predictors of weight or height Z-score of -2 on follow-up, if they start off poor with poor Z-scores on weight and height, they tend to do poorly long term. So that was the odds ratio of 2.4 that we got out there. But what were significant determinants for maternal height? And maternal height had the strongest influence on the eventual height that they gained. And so these were factors which were very interesting that we found that basically weight gain was partly constitutional, partly related to the weight at surgery, and we felt that this is another reason to operate early, to actually eliminate or mitigate this particular variable where we keep the weight Z-score as good as possible and by operating early. So these were the things that we found that influenced eventual weight gain, even including caloric intake. But if you see amongst all the things, the caloric intake had the smallest influence as far as weight gain was concerned when compared to things like maternal height, weight Z-score at surgery. These were very major determinants. So the second challenge that we face in our environment relates to respiratory infection. So it's not uncommon that we encounter a baby who has a pneumonia, who gets ventilated, who gets admitted to the ICU, has a large VSD. Patient is sick, septic, perhaps, and we want to know what to do in these patients. So again, we were faced with this dilemma in the early stages of our program, we were asking this question as to what do you do with the patients who have severe respiratory infections requiring mechanical ventilation? Should we ban? Because there was a theory that at that point that if you do a PA ban and avoid cardiopulmonary bypass, you would probably produce a better outcome. Second question is, when do you intervene? Do you wait for pneumonia to clear off, because that never happens? And then what outcomes can you expect in these patients? So we made up a few set of institutional criteria for VSD closure in these patients. We said, let there be no fever for 48 hours or longer. Let there be a declining count trend if initially increased. So if you have a white cell count of 24,000 and it starts to come down to 18,000, that's good. Or if the platelet counts are very low but they show an upward trend, that's also good. At least partial radiologic clearance. You know that you can never get complete radiologic clearance unless you close the VSD. The other thing we felt strongly was improving blood gases, because some of these patients were interesting. Their lung pneumonia was so bad that PVR would go up and the VSD would shunt left to right to left. So that we said that let there be at least a PO2 of more than 60 and a PCO2 of less than 50 at a FiO2 of 0.4, and we would consider operating on these patients. And then, of course, on echo, we should show predominantly left to right. So we made up these criteria, the first 13 patients that we did. We did not mandate documentation of negative blood cultures, normalization of gas exchange. They were desirable but not mandated. So we went ahead and described our first series. This was published in JTCVS. And in some ways, I think it's a very important paper, because again, addressed a problem that was common, but that was never looked at systematically. So we had 12 babies at that time, and mostly infants, mostly these were all VSDs. Many of them were septic. Many of them had pretty lowest PO2. There was children whose lowest PO2 was in the 30s. And then the maximum PCO2 is again pretty high, you can see in the 60s. And many of them were ventilated for a fairly long period of time. Only a few were ventilated for 1 to 3 days, but there were many who were ventilated for 14, 15 days. And one was ventilated for 18 days. So we basically had 18 patients in the study group on whom we operated on 12, and 6 were unoperated. This was determined by various determinants, so it's a retrospective study, has its limitations. Amongst those whom we operated, we could send home 11 patients. Only 1 died in this initial cohort. And amongst the ones who were not operated, only 1 survived and 5 died. So clearly, the ones who need surgery need to be operated, otherwise they tend to die. So we then have taken this policy. This was 2004 when it was published, but we've then probably done close to 200 to 300 infants with large VSDs, with a surgical outcome which exceeds 95% in terms of survival. In the last, I would say, 200 patients, we've not had anyone die from a VSD, although several have been ventilated pre-operative. So the conclusions that we made was that VSDs and respiratory infection correction is feasible. Early correction should be pursued aggressively once you get the window of opportunity. It has got potential to save lives. Significant morbidity is there, but it's still worth it. There is post-operative sepsis, there's long ICU stay and long hospital stay because of the pre-operative insult. But nonetheless, survival is very good, and it's perhaps worth working on these patients and offering surgery to them, notwithstanding the respiratory infection and also notwithstanding the malnutrition. So these were 2 papers relating to infants, and third problem that we face is pulmonary hypertension. So we'll talk about pulmonary hypertension because that's the third challenge that we face in our part of the world. Okay. So we've got some simple rules here. I'm going to state those rules because this is what we follow, and I'll show you some case examples. So our rule is, if there is a large shunt in the basal state, then irrespective of PA pressure, a VSD is operable. Now that's different from ASD. An ASD could have any significant pulmonary hypertension in an ASD is serious because that's not transmitted pulmonary hypertension. That's not a direct transmitted pulmonary hypertension. Largely reflects vascular resistance issues. Small proportion of it is flow related. But VSD, if you have an unrestricted VSD, you have to have PAH. The difference is that this PAH may not always be related to elevated resistance. The second rule that we follow is age is an important variable, and we have a benefit of doubt for younger patients. So if there is a borderline situation, left to right shunt is not that obvious, but the patient is young, we tend to veer towards surgery. But at the same time, if there is significant doubt on operability, particularly in a child who is older, more than 2 years of age, I think the better rule is not to operate because you really pay the price 4 to 5 years, 10 years down the road. So that's the rule that we follow. And we tend to have this spectrum of situations. Clearly, operable situations are obvious left to right shunts, typically younger patients, inoperable shunt reversal, typically older patients, and borderline situations, which challenges us every now and then. So here's an example. I show this all the time. Infant, tachypneic, large heart, Q in V5, V6, VSD showing echo showing LA-LB enlargement substantially, and predominantly left to right shunt across the VSD. This is an example of a posterior muscular VSD. Now you just have to operate. There is no hesitation here. But to the fellows who are sitting here, it's very obvious, but there used to be extensive debate. There are still institutions where surgeons insist on catheterizing these babies to be sure if they're operable or not. It's a complete waste of time. You are pretty sure in this situation when you have enough evidence of a large basal resting shunt. And we don't go wrong. We never go wrong. On the other hand, if you take a patient who is older, who's 16 years old, now this boy was 26-year-old. It could be not necessarily 26, but 16, 15 also. Who's blue, who has a single second heart sound, doesn't have a large heart, who's obviously Eisenmengerized. Again, there used to be a rule that you should catheterize before you declare somebody as Eisenmenger. Again, I think it's unnecessary. And this patient is clearly inoperable. There's no LALV enlargement. So you should go ahead and recommend that not to operate. You have a clinical spectrum of post-fracture. Operable is clearly there is evidence of a large left to right shunt, failure to thrive, increased precordial activity, MDM at apex, and we all rely quite heavily on that. None of us can recall an instance where if you had a mid-diastolic murmur at apex in a VSD, the patient had problems post-operative. They all fly once you close the VSD. So all those things, cardiac enlargement, increased pulmonary blood flow, and of all this, the most non-specific or difficult to be sure of is this LA-LB volume overload on echo, because it's very poorly defined. We don't define this very well. What is LA volume overload? What is LA enlargement? How do you quantify it in children is not very clear. In adults, you have the aorta-LA ratio, but in children, we are not sure how it is done. In LV sizes, we use Z-scores, but again, this has not been validated. So, I think of all the criteria, the clinical criteria are more useful. In echo, if it's a predominantly left to right shunt, that's useful. But going by just echo evidence of LA-LV volume overload alone, in the absence of other things, is a bit dangerous. So the other hand, of course, you have cyanosis, quiet precordium, no MDM, loud P2, banging loud P2, palpable P2 is a very ominous sign. Normal heart size, peripheral pruning, no Q in V5, V6, predominant RV forces, no LALV enlargement. This is inoperable. And somewhere in between is the borderline situation that we deal with. So we'll take a borderline example and we'll go through that example. So this is a 10-year-old boy who was detected to have congenital heart disease in early infancy but did not undergo surgery. He is asymptomatic except for occasional respiratory infection. It's a typical story. What's very interesting is you often hear this story in older children who present late. So he's done well. Normal growth and development, attending school. He has some class, minimal restriction of activity, but he's pretty much like other children. He's pink. In this particular example, P2 is loud and it was reported to have normally been split, but I'm not sure about the reliability of this. There's the ejection systolic murmur, no hepatomegaly. So he is not in any heart failure. Heart size, if you see the X-ray, there is, so do you want to interpret this X-ray, any one of you, in terms of, operability? There is evidence of perhaps increased pulmonary blood flow. There is some cardiac enlargement. Pulmonary artery is prominent. So far, does it look operable? Yes or no? Yes. Okay. So there's quite a few yeses, which is exactly what we thought. We got a ECG that shows a small Q in V5, V6, but there is also a deep S wave that gets you a little worried. Means persistent RV forces. Axis is not rightward, but going towards the right side, but definitely not rightward. Predominant tall R waves in V2, V1, V2. So this is a bit of a mixed picture, isn't it? This child seems sort of operable, but it's a bit of a mixed picture. I don't have the movies on the echo, but the echo shows more of a left to right shunt than a right to left. There was a phasic right to left flow, but mostly it was left to right. Okay, let's look at the baseline cath data. We decided to cath him. Older child, we wanted to get the numbers. Okay, so does anyone want to interpret this cath data? Does anyone want to comment on QPQS? Notice the striking things. There is a minimal aortic desaturation, but if you use this aortic saturation and this SVC saturation, you have an AVO2 difference of 20. And then if you take this pulmonary venous saturation and this pulmonary arterial saturation, what do you get as AVO2 difference? So 20 by 13, QPQS is 1.6:1. Then when you look at this PA mean, it's pretty close to systemic. Look at PA diastolic. It's only marginally less than aortic diastolic. These numbers. Should you operate on this patient? So should you, what do you do now? What do you want to do? So somebody writes oxygen study and I want to challenge that. What does oxygen study do? Everybody is still doing it when it is conclusively, repeatedly shown that it is of no additional value. You would do an oxygen study if a child is having resting pulmonary venous desaturation. Then it makes sense to do an oxygen study. Otherwise, by hyperoxygenating somebody, you only confuse all the numbers. You do not produce an improvement, and study after study has shown oxygen study to be useless. So I would challenge the notion of giving oxygen, although we tend to do it. So I'm going to give you the numbers anyway, basal state numbers. These are the basal state numbers. You want to operate on this patient? You are surprised, isn't it? Your clinical exam, your echo, everything was pointing towards operability. You cast this patient and you're left really confused. Okay, we would test reactivity. Having condemned oxygen study, we still gave oxygen and saw the response, because after that we gave nitric oxide and saw what the response was. So let's look at all the numbers. Oxygen consumption is assumed. It's a mistake to think that this is the most exact number. It's assumed. QP, baseline 6, 1.3:1, sorry, 1.34:1. It becomes 8.6, becomes 8.9 on nitric oxide. QS 4.4, and more or less doesn't change too much. So the QP-QS ratio goes from 1.3 to 2.1. PVR comes down to 6.7 on nitric oxide. So what do you want to do? Why? So where does that 6 come from? Why do you say 6? What study? How? Which guideline? Where is it published? I was part of the guideline. I'll tell you. The guideline was published in Pulmonary Circulation and was a consensus statement of 18 pediatric cardiologists from the globe, 2 of whom were from India, Dr. Kothari and myself, and probably Dr. Krishna from Chitra, and there were others. We all got together and made up numbers. There is no data, good data. And what is very important is the basal state, not the post-nitric oxide. Your patient, after surgery, is going to go out and breathe room air. He's not going to inhale nitric oxide. So, to assume that giving oxygen and having a reactive pulmonary vasculature would get a lot better if you close the shunt has got no validity. So, at the basal state, it is recommended that if your pulmonary vascular resistance is more than 6, you should be worried. If it is more than 8, you should perhaps not operate. Basal state. Post-oxygen has limited value. Cutoff is somewhere between 6 to 8. But I'll give you those, the studies have got lots of those numbers written out, and I don't go by those numbers, I go by everything. So we put everything together in this child. Because we liked the clinical situation. We found the resting sat clinical situation to be good. We decided to operate on this child. We did that. We closed the VSD, we left behind a fenestration. There was a large PDA that we ligated. And he did beautifully. Uneventful. PA pressure was 1/3 to 1/2 systemic based on PA lines that are placed early after surgery. He was extubated on day 2, second day, that is next post-op day. Echo at discharge showed a fenestration which was left to right. Gradient was 60, it looked good. We discharged on sildenafil. So all very good, isn't it? Are you happy? We need to follow. And what did you find on follow? We catheterized him on follow. PA pressure was half systemic, but remember, non-normal. And we got a PVR of 5.6 wood units. So PVR never normalized. There's insignificant shunt across the fenestration, and balloon occlusion of the fenestration during cath did not impact PA. So at this point, we're worried. I'll tell you another story. Similar case. Large PDA, 4-year-old, borderline numbers, of device done, 1-year follow-up, half systemic, 4-year follow-up, 2/3 systemic, 5-year follow-up, systemic, 8-year follow-up, suprasystemic, 9th year, cardiac arrest, sudden death at school. So the point really I'm trying to make here is that we don't have the duration of follow-up that we need to make decisions on borderline cases. So it's perfectly reasonable to leave them alone. If we decide we need to do something, we should do it systematically. Collect all the data. So we were to take a global national registry of borderline cases and have a 5-year follow-up, we will have answers to the questions. Or at least 5-year follow-up. The point is, this is very, very important. In fact, all of you, the next generation should be planning on doing something like this. That will give us an idea as to what is to be done. So I think if you look at the spectrum, operable to inoperable and borderline, you have this notion that cath would convert it into white and black, the gray zone. But I think the cath only narrows down the gray zone. really it doesn't convert. In the real world, it actually makes the gray zone narrower, perhaps. So essentially, large VSDs are challenging. I think if it's an infant with a large VSD, we sorted out the problem more or less. In most Indian institutions, we are able to operate on them and send them home. There's no problem. It's only the older children who are bigger problems because we don't know how to handle their data very well. And unless it's a clearly left to right shunt and the numbers are good, we should hesitate to operate. So we should get that data, all of us, through a combined database. Now we'll just do briefly restrictive VSDs, because that's another contentious area. So why would you want to operate? I've listed out 3 reasons. Why would we want to operate? 3 reasons that are quoted by most people. You want to operate because you want to eliminate the risk of endocarditis. You want to prevent aortic regurgitation through increasing prolapse. And the second thing that I've put in quotes is because you think there is LV volume overload. Again, very poorly defined. We don't know what it is. Nobody knows what it is. Some LV enlargement, how much LV enlargement, we have no data. So this is another often written reason. The 4th reason I have not even listed, which is murmurectomy, which people do just to get rid of murmurs so that the patient can seek employment or some insurance reasons, or sometimes not even that. So we have to understand that restrictive VSDs, we have to think about balancing 2 situations. So it's do something or do nothing. And restrictive VSD closure is not as trivial as PDA closure. It has procedural complications. Heart blocks do occur. Incidence of heart block is anywhere between 1 to 3%, even with no matter what device you use. Incidence is particularly high in younger babies. We have to be careful. Aortic and tricuspid injury can occur. Endocarditis can occur even after you put a device. I have a case report of an endocarditis in the previous issue of the journal on the device. And other events, you'll be surprised, doing a VSD closure, it's not totally a trivial procedure and costs money. Doing nothing, you're worried about endocarditis, but endocarditis is manageable in most circumstances today. Focus should be on dental hygiene. We no longer recommend prophylaxis for VSD closure for VSD patients. So I don't think it's such a big deal today in today's times. But essentially, the number needed to treat. So you need to close 1,000 VSDs to prevent 1 endocarditis. It's very important to recognize that. Symptoms, well, they are asymptomatic. Exercise capacity, we do not document them. LV volume overload, we don't understand. And we often don't measure these scores before we take decisions on these patients. Aortic valve prolapse is a concern, but that's primarily a concern in subpulmonic VSDs. And in perimembranous VSDs, aortic valve prolapse behaves completely differently. It's not something that progresses in a predictable fashion. So I think for restrictive VSDs, we have to be very careful before we decide on indications to close. We violate the indications every now and then, particularly when we find LV and LA to be enlarged, but we have to think. And that's a very borderline area. Particularly, I firmly believe if you're using ADO2 to close VSDs, then that VSD doesn't need to be closed. Because it's so small that you can only close it with an ADO2, you probably shouldn't be closing it. So I think when you reach that level, there are exceptions. And there are occasional situations where an infant is in trouble, so you close it, or there is a post-operative residual VSD, you close it. But just closing a membranous VSD because it's there, I think is not justified. So until we have better data, and we're not collecting that data, until we have that, we should use careful judgment. That's my feeling. And doing nothing is not a bad thing. You can talk to the families, and you often can get convinced that this is really not worth closing. But many families get obsessed with the murmur and keep going from doctor to doctor until somebody offers closure. And we need to really think. We can talk to the family, and usually it works very well. And we need a very good multi-center trial with very clear entry criteria whether this is beneficial or not. That's going to be very hard to do. Okay, and we should probably consider cath closure only in situations where we would advise surgery, and that's something that we should do. We should not just lower threshold because it's easy to stick in a device. That's the way I think we should approach VSDs in the cath lab. So I think this is the core issues relating to management. If there are questions, I can take them, and happy to answer a few questions. I'm done with my talk. So is there, you want to ask subaortic VSD? What do you mean subaortic VSD? So the question is subaortic VSD with aortic valve prolapse, and I'm asking what is subaortic? Wait, what is outlet? Outlet is subpulmonic. Subaortic is the angiographic term that is used for membranous VSDs. But subaortic VSDs in common parlance is membranous VSD. So there are two subsets, subpulmonic VSD and perimembranous VSD. Subpulmonic VSD, the aortic valve is unsupported, has a real tendency to prolapse. Prolapse is increased as the VSD gets smaller because of the Venturi effect. It sucks in the aortic valve and tends to prolapse. With membranous VSD, it's not clearly understood. You do see sometimes prolapse, but the progression of that prolapse is very different from subpulmonic. And there are studies that are carefully documented natural history of membranous VSDs with mild AR. And the progression rate is very different. So it is reasonable in a membranous VSD which is restrictive with mild aortic regurgitation to wait. Many surgeons don't agree with me. They still think that because the aortic valve is potentially a part of the aortic valve is unsupported, the non-coronary cusp, right coronary cusp commissure, it may still be worth. I guess they can be taken on a case-by-case basis, but by and large, membranous VSDs behave differently from subpulmonic VSDs. Subpulmonic VSD, if there is aortic valve prolapse, is a strong indication to close the VSD. The membranous VSD, it's not unreasonable to watch closely. So that's the way I would approach the two situations. Any other questions? Otherwise, we can sort of wind up. Nobody does that now. We don't actually look at VSD in terms of relative size with the aortic annulus. We take a whole lot of other, it's a composite sort of combined estimate of what you think is the size of the VSD. I think the most important data is whether it's restrictive or not. Is there a pressure gradient across the VSD? That tells you to some extent what is the effective size of the VSD. VSDs, especially perimembranous VSDs, are very difficult to come up with an accurate number for size because there's very difficult to define the margins. It's very dynamic. And if you actually see 3D recordings of muscular, even membranous VSDs, there is a lot of dynamicity to when you record the VSD. So I think sizing of the VSD per se, just going by numbers, doesn't help very much. It's one of the things. Many other things relate to the gradient, the downstream consequences in form of LA and LV enlargement, the symptom status of the patient, everything together. We put the whole thing together to decide whether a VSD is significant or not significant, and then take a decision. Yeah, question. I'm not able to see the question. I'll see here, sorry. Books give, how do I get that? Let me just escape. Frozen section, biopsy of the lungs to decide grading. Now, it's not being practiced. About histology, lung histology is not being practiced for 3 or 4 reasons that I'll list you out. One, there are not many good pathologists who can interpret this well. 2, lung changes with vascularity tends to be not uniform. There are parts of the lung that are normal, there are parts of the lung that are not so normal, and you may not get the right part when you do a biopsy. 3, there are 2 criteria for lung biopsy interpretation. The Heath-Edwards criteria is the conventional criteria. The second one is the Marlin-Rabinovich morphometric score. The first criteria is not specific enough. The second criteria is very hard. You have to actually quantify and measure a lot of things like the number of vessels to the given to the alveoli, the vascular alveolar ratio, arterial alveolar ratio. Then you have to look at medial thickness, a whole lot of parameters which people are no longer sort of having the expertise to do it. So I think mostly it has been given up, lung biopsy to decide. Any role for PA banding in VSD? I think there is a role for multiple complex VSDs that are hard to close in the single set. I think we do occasionally have a Swiss cheese septum that we really find it difficult to handle. And then we can consider a PA band in some of those situations. Very recently we had a patient whom we had Swiss cheese septum where we banded in a very specific technique which we used. We encouraged the surgeon to use Roline to secure the band, and then we disrupted the band in the cath lab after the VSD had closed. So we could avoid another open heart surgery. But essentially in our population of muscular VSDs, I would say 5% require a band. Majority we are able to operate without a band. Subpulmonic VSD with mild AR and early infancy, when to operate? I would operate straight away. I wouldn't delay. I don't think it's a good idea to wait when there is mild AR, which is attributed to aortic valve prolapse. It can progress rapidly. The likelihood of progression is most rapid between 3 to 11 years of age. Studies have shown that progression is particularly rapid in that period. So it's worth doing it. Small subpulmonic VSD, again, I would follow very closely the first evidence of aortic valve prolapse, I would operate. So that's the way I think it's worth having. Also, the subpulmonic VSD is particularly easy to close surgically because the surgeon has to just open the pulmonary artery, doesn't even have to open the right atrium, and the VSD is accessible from there. So I would encourage, I would personally go for a much lower threshold in this situation. Any other questions? And I think we